now I'd like to introduce Dr. Taylor. She's one of ASHRAE's distinguished lecturers, and essentially the distinguished lecturer program allows gives access to qualified lecturers for ASHRAE meetings to talk about relevant industry topics. Dr. Taylor works at the intersection of architecture, design, indoor air quality, the microbiome of the built environment, and human health. She's also been a member of ASHRAE's epidemic task force, so she's very well qualified to take us through indoor air quality as it relates to humidity and how things have been changing with humidity since the pandemic started. So Dr. Taylor, take it away for us.
Great, thank you so much. I think I'm supposed to tell everybody that everything I say is not necessarily the opinion of the full ASHRAE epidemic task force. I think we've been told to say that. Now that I've got that behind me. I titled this, as you can see it, that building professionals are the physicians of the future, because all of you who have anything to do with buildings, building construction, building management, HVAC design, HVAC operation, commissioning, the future of public health is really in your hands. And you'll see why I firmly believe that. So again, I'm really happy to be here today. This is some of the stuff that you might really not be interested in, all the other things I'm doing. So in the next 45 minutes, I'd like to talk with you about these three areas. One is my journey to you as a physician, and how I came to be so honored to be speaking to everyone in the audience. Secondly, I'd like to show you some studies on human beings indoors. And lastly, I'd like to point you towards what I see as the future and to hopefully get your feedback through this virtual platform, your feedback about how we can move forward together. So to start with bridging divides. So I'm a physician. I graduated from medical school quite a while ago. And this was me when I was in med school. Like a lot of 20-some-year-olds, I wanted to have an adventure. So I went to Papua New Guinea for 4 months to practice medicine. And you can see the conditions were, you can see the geography, you can see the plants. The hospital that I was stationed in, my main center was in Wewak, New Guinea. And the hospital, as you can see, didn't have the same sanitary surface conditions anyway that we're used to in this country. Family members would stay in the beds and help take care of patients. In the middle, you see a men's tuberculosis ward. Beds were pretty close together. And on the right, that's me in the operating room, sort of gawking at this patient we were about to do surgery on. And if you can see, I'm wearing flip-flops. That's what we all wore in the operating rooms. So but despite these conditions that don't exactly look like the image of perfect surface hygiene, these patients did really well. They didn't stay longer than we expected from infections that they got while they were in the hospital. And in general, their recovery times were very quick. So perplexingly, in this country and in most developed countries, going into the hospital is a really risky proposition. Before COVID-19, it was the third leading cause of death in the United States for reasons totally separate from why you went into the hospital. The gentleman on the left is my son's, the dean of his medical school. He had a ski injury, he tweaked his meniscus, went in for a one-day procedure, came out 4 months later, almost without his life. The little girl in the middle is one of my patients with leukemia who survived her leukemia, survived chemotherapy, and almost died of an infection. And those numbers are even worse than what we usually read about. So it was this question of, why are all these people getting infections in the hospital? And does the building have anything to do with it? So as a physician, I talked to my colleagues. I said, why is it that we're seeing these clusters of infections in certain parts of the hospital? And they said, just wash your hands, prescribe the right antibiotics, and that's all you can do. And when I tried to talk with the facility managers, they said, we don't like doctors. We're not going to talk to you. You wouldn't know what we're talking about anyway, which was true. So I went back to school somewhere in my 40s and got my master's in architecture and engineering because I needed to understand buildings and how they were designed and how they were operated. And when I think about it, again, going back to my medical school time, this was me with my very cherished mentor, Dr. Folkman. And he and I were doing oncology research on black mice. We were trying to understand how blood vessels grew to tumors. And one night I went in around midnight and a lot of our mice were dying. Control mice were dying, non-control mice were dying. So I called him up and I said, something's going on. And he came into the lab in the middle of the night, and I'm sure he had a case the next day. And we scrubbed the research operating room down from top to bottom. And Dr. Folkman, who's like one of the most wonderful, wise people in the world, said, never, ever underestimate the power of the environment in your health outcomes. Whether you're a black mouse or a human being in an office building, never underestimate that. So that made a really big impression on me. So if we take a look at our environment, if we go back through time to a very long time ago, you know, our buildings or our shelters were quite primitive. They're pre-existing caves. There was a lot of communication between outdoor air, soil, plant material. And then as our building materials became more sophisticated and our building strategies, we kind of evolved into more and more enclosed structures. We had increasingly sophisticated sanitation systems. And by the Industrial Revolution, unless you were in farming, most of us lived indoors. And at this time, we weren't really trying to coexist with nature. We were really reaping the benefits of nature through industry. And then as we keep on going, after the 1970s and the oil embargo, we tightened up our buildings. We really began to focus on energy conservation and sustainability. But it's interesting because from a high level, if you take a look at the advances in building technology, unfortunately, we've also seen a coexisting rise in certain diseases. For one, infectious diseases. We've also seen an increase in many inflammatory-based diseases, such as inflammatory bowel disease and other chronic diseases that you would never think are related to particles or inflammation. Things like diabetes, heart disease are related to particles in our environment. So we're now seeing a rise in certain types of diseases. And clearly we're struggling with COVID-19. So one of my other colleagues said, you know, we shape our buildings, then they kill us. It's like, thanks, Dr. Diggerman, that's really depressing. And it's not meant to be depressing, but it's meant to be something that we need to take a look at to see if we are managing our buildings in such a way that a change might increase our health. So here we are in 2020 with this coronavirus called the SARS-CoV-2 virus. It's a single-stranded RNA virus, which is interesting because single-stranded RNA viruses mutate really, really easily. They don't have the sort of the proofreading mechanisms that most viruses and bacteria have. So many new strains are formed. And if one of those new strains finds an environment that no other organism can live in, such as a microclimate in a building, for example, and they find a new host, such as a human being without immune defenses, then you have a pandemic. And that's what we're seeing with this coronavirus. But again, it's interesting because if you go back through time from an infectious disease perspective, if you go back to the 1400s, the Black Death or the bubonic plague, we said was spread by infected fleas. So people, you know, shut their doors and did a lot of things to keep rats carrying fleas out of their homes. Subsequent to many centuries later, actually 2 years ago, not we, because I didn't do it, but the corpses in London of people who died from this were exhumed and they're reanalyzed with metagenomic analysis tools. And what was discovered is that, in fact, infected fleas on rats was not the primary transmission vector. It was the pneumonic plague, or the airborne route. The Spanish influenza, airborne. And now COVID-19, we're finally having seen that our public health agencies are recognizing that long distance spread through the air is probably the most significant route of transmission. So if you're like me, you're wondering what is it about human nature that we don't want to acknowledge airborne transition? Well, it's scary for sure. But if we recognize it, then we can handle it. And if you go back and look at this document in 1912, so this is 6 years before the Spanish influenza, this Dr. Chapin decided that if you talk to people about airborne transmission, then they won't wash their hands and they won't focus on surface transmission. And he said, furthermore, let's not talk about airborne because it's scary and people don't want to think about it. So not a very good rationale, if you ask me. We need to think about airborne transmission. This actually is, I was on a conference call with Dr. Fauci, and you might recognize this video. This was done by Lydia, whose name will come up later in this presentation. But Dr. Fauci was backing up, during this video. And even he is now recognizing how important the management of indoor air is in decreasing disease transmission. What's the CDC been saying about it? I don't know if you follow the news, but CDC said, it's not airborne. Maybe it's airborne. Nope, we decided it's not airborne. Well, now it's airborne. So the CDC has waffled on this question, but it is airborne. So let's take a look at some studies that will begin to reveal some strategies that we have to decrease transmission in our indoor environment. We decrease transmission of this viral illness, but other illnesses as well. And we'll talk about how we can learn the best strategies for managing our buildings, specifically for occupant health. So, I showed you that slide that had an increase in disease, in many diseases, as we've tightened up our buildings. So is in fact there a relationship between building management and infectious diseases? And it's really serendipitous because right when we're seeing an increase in these diseases, we have some new tools that will actually help us answer the question about whether or not there's a relationship between building management and diseases. So if you think back to biology and think back last time you went to your primary care provider with a sore throat, they probably swabbed your throat, plated the Q-tip out on a Petri dish, incubated the Petri dish, and then looked under a microscope to see if anything was growing. So that's called tissue culture analysis of bacteria. And that's very valuable, but you only identify the bacteria that you're looking for. And starting in 2003, when we finally sequenced the whole human genome and created Dolly the sheep from cloning, we used another set of tools. They were genetic analysis tools. We call them metagenomic, or PCR is the primary test. But using these tools, we can now look at the DNA and RNA fingerprints of all of the bacteria and viruses and fungal organisms in our body, on our body, and in our buildings. So what we've learned by moving from tissue culture, sorry, that's my dog, Louie. What we've learned from moving from tissue culture to metagenomic analysis is that as human beings, we are only 30% human by cell number. 70% of our bodies are made up of bacteria. And we're shedding those bacteria into our buildings all the time. So let's take a look at this video. I really like this because it gives you such a good sense of our interaction with the indoor environment. So as I'm talking to you and you're all breathing, maybe talking to someone else in your home, little particles, little droplets leave our airways about 100 microns in diameter. They carry all of the particles, including microbes, bacteria, and viruses that live in our mouths, our noses, our sinuses, that come off of our skin. This is all normal. Most of these microbes are good for us. We couldn't live without them. We couldn't digest our food. We couldn't train our immune system if we didn't have them. Our digestive tract is filled with bacteria. If she had a gas problem, you'd see that. Luckily, we don't usually have immunofluorescent lights on. And you can also see that there's a very active exchange between surfaces and the air. So as we think about surface hygiene, we have to remember that how we're managing the air is going to affect the cleanliness of our surfaces, and vice versa, because we live in a 3D world. So surfaces and air communicate. And then depending on how sealed your buildings are, you'll have more or less exchange with the outdoors. But if you think about this process of us human beings shedding our microbes into a building, the thing that is really remarkable and that makes your work so important now during COVID-19, but before COVID-19 and after, how the indoor environment is managed. So surfaces and air, indoor air quality, actually will select which of those microbes that we bring in and that come in from the outdoors. The indoor environment determines which ones survive and affect, subsequent occupants in the building. So given that we spend 90% of our time indoors, how the indoor environment is managed is really the primary driver of health and disease for human beings. So that means that managing buildings from the perspective of a healthy human being is incredibly important. So let's think about COVID-19. What if this woman comes to your house on Thanksgiving? This is not me, by the way, and is doing this. And you're like, oh my gosh, how do I protect myself from getting sick? This can be the hated mother-in-law. My son just got engaged, so I hope I won't be one of those. But anyway, what if this woman comes to your home? What can you do to protect yourself and your family from getting sick? Well, there are really three places you can stop the spread of infectious disease. One, you can restrict your viral exposure. In other words, you can lock your door, tell her to go away. You can make sure she's wearing a mask. You can stay far away from her. And the second place is how you manage your building. And this is really where engineering controls focus, managing the indoor environment to decrease disease transmission. And thirdly, on the right, you can take care of your health. You can get enough sleep, you can exercise, eat well. Hopefully there'll be a vaccine out that's effective to bolster our immunity. So, but it's really the middle where we focus our environmental strategies. The first step, restrict your viral exposure. Again, we're told to stay away, wear masks. Guidance has been a bit confusing about these steps, to say the least. But let's talk about the middle part. How do we know how to manage our indoor environment to support our health? So if this is your one of your family members, and the sun's coming in and this stuff is in the air, we're being told about a lot of things we can do. Filtration, outdoor air ventilation, UVGI, bipolar, a lot of things. Now humidification. But how do we know which of those truly support health? So to answer that question, think about how you would set up a study where you're integrating human health metrics, like physiological health metrics, with the indoor environment. So what would you measure indoors and what would you measure in the human being? So for example, would you look at how many days of school your kids missed? Would you think about how many colds or influenza infections you get and relate that to your home? Well, a great place to do this sort of study, where you're looking at humans indoors, is actually a hospital. And the reason that's a great place to do the study is that we're already gathering so much data on hospital occupants. So what I want you to do now is think about the family member or yourself who's in the hospital bed, if you've ever been sick. Don't think of them as your loved one. Think of the patient now as the Petri dish or the litmus paper. And patient outcomes are going to tell us if we're doing things right or wrong in a hospital. So this is a study, actually was in your area, in the Chicago area. in an academic hospital, brand new hospital, LEED Silver. And this study took place over about 13 months. So there were 10 patient rooms that were monitored with all the parameters you see listed there. Data was gathered every 5 to 30 minutes. So temperature, hand hygiene, protocols, room pressurization, lighting, CO2, humidity, traffic in and out of the room air changes, outdoor air. So all of those environmental parameters were gathered. And then I asked about following the patient outcomes. So I was allowed to do that. So we took patient infection rates, and thanks to statistical analysis, we were able to correlate about 400 patient outcomes with 8 million data points about the environment to see if in fact there was a relationship. So we sent all these data off to our statistician, who came back and told us the most powerful correlation was that when the relative humidity in the patient room was low, the infection rate was high. So you can see the relative humidity, which is the blue line, as it went from the winter into the summer and back to the winter, went from a low of about a little less than 32%, a little over 40% in the summer. And when the relative humidity was low, the infection rate was high in those rooms, in those patient rooms. So I saw these data and I thought, that's ridiculous. And it's wrong, because it's really the opposite. If you have higher humidity, it's like watering a garden and you're gonna have more stuff growing. So we fired our statistician, said, you're wrong, you missed some other variable. And they came back and said, we're not wrong, but go ahead, fire us anyway. So we hired another statistician who came back and said the same thing, that an independent correlation was between low relative humidity and higher infection rates. I was still skeptical. So we embarked on another study. This one's 4 years in the running in a nursing home. We did the same sort of monitoring the indoor environment. And once again, if you looked at the infection rates in the elderly population in the nursing home, that when the relative humidity, which is the x-axis, was less than 40%, you can see that especially respiratory and gastrointestinal infections, which are the blue and the orange lines, when the relative humidity was less than 40%, the infection rate was high. But as the relative humidity indoors progressed to 40%, we had this all-time low, when the indoor relative humidity was 40 to 60%. And those other lines show cellulitis and eye infections. And the red and the purple trended down. The green, line, which represents urinary tract infections, those infections had to do with like mobility and hygiene. But you see here a sweet spot, 40 to 60%, had the all-time lowest infection rate. This nursing home subsequently has maintained their indoor humidity with humidifiers above 40%, and they had no COVID-19 outbreaks this winter. And sort of 2 control nursing homes nearby had significant rates of illness. So this was a really convincing study. Whoops. But because we didn't have a parallel control point in those, we can't really talk about causation. We can only talk about correlation. But in this study, which was done by the Mayo Clinic, they took a preschool, and they were looking at influenza illness in the kids. So they took half the school and they humidified it to 45%. I think it was a steam unit. They let the other half of the school do what happens in the wintertime in northern Minnesota, bring in outdoor air with a given absolute humidity, warm it up, and the relative humidity plummets. So in half the school, the relative humidity in the wintertime hung around 20%. In the humidified half of the school, they kept it at 45%. And the findings were pretty remarkable. Number one, they found that in the humidified part of the school, there were many fewer particles carrying the virus. That's the second column from the left. Furthermore, they found that the actual activity of the virus, of the ones that were there, those viruses were less infectious. They're less bad. So there were fewer of them, they weren't as infectious, and ultimately there were fewer children sick due to influenza, so, which you would expect. And they repeated this study in 4 other schools and found the same thing. So again, this begins to point to causation. Dry air allows for greater viral transmission. So now these next couple slides are like hot off the press data. This report has been submitted to Nature. So it's in press, so don't take screenshots and like send it around, please. Although you can have the presentation, so I'm a little contradictory. So this very industrious MD PhD student named Connor called me up in March and said, hey, I've been looking at some of what you've been writing about. Let's do a big study, a worldwide study where we gather as much data as we can on the metrics that I'll show you. And we can put them through the MIT data grinder and see if we can find any correlation between COVID-19 disease and indoor conditions. So again, we're wondering why does this disease, as well as others, occur in these sort of geographic stratifications? So Connor found data feeds from these sort of 3 buckets. 1, government policies and public health measures. So school closing, workplace closing, public events that were canceled, restrictions, stay-at-home requirements, everything you see in the upper left. How much money was poured into disease prevention, investment in vaccines, any sort of socioeconomic metrics. He also looked at, we looked at the demographics and testing data that we could get hold of. So we look at population density, age, comorbidities, poverty, hand washing capability, hospital number of hospitals. And then we looked at ambient environmental variables. So latitude, longitude, precipitation, temperature, humidity, precipitation. And initially we weren't able to actually measure indoor relative humidity. So we calculated it from outdoor temperature and absolute humidity and brought the indoor temperature up to comfort levels and calculated a relative humidity. The really wonderful thing is we were able to corroborate our calculations with measurements, sort of spot measurements around the world. And the calculated indoor humidity was very, very close to the actual measured indoor humidity. Okay, so those are the data feeds. The analysis was crazy. I mean, I've learned more about statistics than I could ever have imagined. And I still have sort of a cursory understanding. The MIT folks were determined to disprove any connection between disease and indoor variables. So they tried and tried and tried. They subjected this massive amount of data to, artificial intelligence analysis, supervised machine learning, unsupervised machine learning, where you just put everything in and say, are there any correlations? As well as these other things you can see here. So what did we find? So the MIT students who were determined to disprove any connection came back with their tail between their legs, showing that around the world in 125 countries, their most powerful correlation with disease was the indoor relative humidity, which is mind-boggling. So if you look at this graph, the blue line here, the sort of jagged line that goes up the left side of this chart are the new deaths. And the dotted line is indoor relative humidity. You can see the pandemic starts. This was not, this is North America, but the same statistics held in South America. Pandemic starts, relative humidity was low. And as the relative humidity rose, the death rate came down. And if you take all of these data and you put them into what's called a lowest fitness curve, there are multiple lines on each of these graphs because of the time offset between weather change and deaths. But again, you can see that both daily new cases and daily new deaths with the time offset was related to the indoor relative humidity in a very significant way. So it's kind of obvious here, 40 coming up to 60% relative humidity indoors have the lowest number of new cases and new deaths. So this is really powerful data that we need to pay attention to. So maybe, hopefully you're still listening and maybe you're wondering, well, why? What goes on? How does humidity relate to infectivity and disease? Well, so as I'm breathing and you're talking, again, these droplets come out of our mouths and noses, and those droplets, those aerosol droplets, contain all of the salts and the proteins that are in your airways. And they come out of 100% humidity environment, and they're about 100 microns in diameter. And if you're maintaining your ambient humidity between 40 and 60%, those droplets shrink. They shrink to reach equilibrium with the moisture content of the moisture equilibrium between the inside of the droplets and the ambient conditions. So the salts and any microbes in those droplets become concentrated to a certain point. If your air is drier than that, if your air is less than 40%, those droplets continue to shrink down. And we think that when the air is dry, those droplets are more infectious, because by the time they get to that small, less than 3.9 micron diameter, the salts are concentrated to the point where the microbes inside the droplets are actually preserved. So those tiny droplets, they travel through the airborne environment, they land on a secondary host or person, rehydrate, and they contain very infectious bacteria or viruses. But at that middle 40 to 60% humidity, the concentration inside those droplets is sort of a mid-range. And we think that instead of being preserved, the microbes are actually inactivated or basically killed in the mid-range humidity. We're still trying to figure that out, what the mechanism is, but that's our best hypothesis. What about this coronavirus? So if you look on the how am I doing for time? I guess I'm okay. If you look on the x-axis, which is relative humidity, and the y-axis is the infectivity or the viability of the viruses, you can see at all temperatures. So the blue line, sorry, my covered up. The blue line is 20%, 20 degrees centigrade. The black line is 4, and the red line is 40. So when it's super cold, which is the black line, you can see the infectivity of the coronavirus as the humidity rises comes down some, doesn't change all that much, even with a logarithmic scale. The blue line, which is where we maintain our buildings, you see a dramatic decrease in activity at around in that 40 to 60% zone. At the red line, which is at 40 degrees centigrade, you still see fastest inactivation in that 40 to 60 relative humidity zone, but nobody wants to hang out in a 40 degrees centigrade building. But the fastest inactivation of the coronavirus was in this range. Okay, so we've talked about some factors, specifically we've talked about humidity to help decrease transmission in your building, decrease transmission in your breathing zone, and decrease activity of any viral particles that might be in your building. But the third column, your health and your immunity, again, we don't, as engineers or building professionals, we don't really think about the building as bolstering your immune system. You leave that up to the healthcare providers. But interestingly enough, about a year and a half ago, Yale University published this paper. It came out in PNAS, which is an awesome journal. It was done by Akiko Iwasaki, who's the head of the immunobiology lab at Yale. And her lab was asking the question of why is it that when the indoor air is dry, bring in cold outdoor air, warm it up, it dries out, what happens, if anything, to our immune system under those conditions? Because they looked at vitamin D, looked at melatonin, looked at other conditions, and didn't find they didn't find other factors that explain the seasonality of some respiratory illnesses. So they decided to look at how low relative humidity affects your respiratory immune system. So basically they were saying, why is it that if you are exposed to influenza in the spring or fall, you know, you might get a little sick, you might feel crummy, but you don't get really sick for the most part. But when it's wintertime and you're in low relative humidity, that's when we tend to get really sick. So how does our body protect us from respiratory infections, viruses, or bacteria? So say that woman comes into your home, starts coughing, you run the risk of one of those droplets carrying a virus. You run the risk of that being inhaled into your airways. The first normal line of defense in our bodies is the mucus that lines our nose, sinuses, mouth, down into our, deeper into our lungs. And within that mucus layer are these little hairs called cilia that are constantly washing upwards to help prevent stuff from getting into our lungs. Because once it gets in our lungs, we're really vulnerable to infection. So these are the normal steps. Subsequent to the mucus and the cilia, if something does get by those steps, there are these other cells that come in, macrophages and dendritic cells. These are immune system cells that secrete interferon, which is a very protective protein. And if necessary, the rest of our immune system is brought into the battle. But what their lab found was that all of these steps are impaired when the ambient humidity is at 20%. So not only is that mucus too thick, so it doesn't trap particles, the cilia can't move when the mucus is viscous. Those are kind of intuitive changes that, you know, you might have kind of expected. But they also found that the cells in your respiratory tract cannot synthesize the protective proteins that need to be there and that are synthesized at 50% relative humidity. So your body doesn't make the same amount of interferon. It doesn't recruit the rest of your immune system. So these are changes that they're still looking into, but it's the impact of low relative humidity on your immune system is very significant. Dry air is very harmful to your respiratory immunity. So let's talk a second about interferon. So interferon is that protein that's produced by your respiratory epithelial cells. At 10% relative humidity, you can see how little interferon is manufactured by your the cells that line your airways. Versus at 50% relative humidity, the interferon levels are nice and high, right? That's a good thing. So let's take a look at what happens with bats. So this virus may have come from the bat population, but bats pretty much, they live with viruses. You know, they get infected by viruses. They live in communities like we do. They live for a pretty long time. But despite the fact that bats can harbor viruses and the viruses can infect them, they don't really get that sick and they don't die like we do. So of course, this is something people are looking at. They're like, well, why? Why do bats, which are also mammals, why do they survive so well? So they looked at the genetic makeup of bats. That didn't explain it. They looked at vitamin D in rats. That didn't explain it. But what did explain it, we now know that bats living in bat caves, bats produce very healthy levels of interferon. And so that interferon, they think, is what protects bats from severe disease. So the reason I'm showing you this is it's another connection between the indoor environment and our health. When the relative humidity is low, the mucus is thick, our cilia doesn't work, and we don't make interferon, which may be a key protein in protecting us from severe disease. So I think that keeping our indoor environment between 40 and 60% is incredibly important. And it's a very holistic approach to protecting our health indoors because it covers both of these categories. It keeps the air and the surfaces in a healthier state, and it supports our immunity. And as a matter of fact, if you look at all the different viruses, different categories of viruses like polio, influenza. Viruses are categorized based on their membranes. So if you look at both the lipid and the non-lipid membranes, viruses, if you look at the different types of bacteria, and if you look at clinical human studies and relative humidity on the bottom, we're seeing this sweet spot, 40 to 60%. And I think Mother Nature has given us an opportunity to survive against these rapidly evolving pathogens. Because if you think about it, when we were living in caves, even when it was cold out, the relative humidity probably stayed in a pretty safe range. And if you're wondering, well, then why do we send our sick people to Arizona? Think about the outdoor conditions. So it would be hot and dry. But as soon as you walk into a house, even if it's not air conditioned or doesn't have like evaporative cooling, just that change in temperature, going from warm outdoors to air conditioned to indoors, is going to bring the relative humidity into a better range in hot climates. But we really get into trouble with disease in cold geographic areas where we have to bring in outdoor air and heat it up, and we don't humidify it. But if there's a clear ROI, if there's a clear cost benefit to humidifying in a building, you can believe it's done. So at the NIH, if those primates that cost quite a bit of money, and if they die, they mess up a whole experiment, they're housed in 40 to 60%. Maybe some of you listening do vivariums and you know what the specs are. If you're an astronaut in the space station, you're in 40 to 60%. NASA knows how important it is. Or if you are like a valuable painting or circuit board or piano or a book, you're going to be in a museum or a data center with a relative humidity 40 to 60%. So it can be done. And actually, this is my dear son, the one who just got engaged. And he and I were hiking in Peru about a year and a half ago. We were in the middle of nowhere. You could kind of see that trail was like one of the good trails. So we were hiking and hiking, and we came upon this mausoleum, this little stone building. It had the bodies of important village leaders, people who died, they were embalmed. They were kind of curled up and covered with cheesecloth. And you can see in this mausoleum, there's a humidifier, dehumidifier on the right, and a thermometer and hygrometer on the left. So we hung around long enough for the building manager to show up. And I said, so what are your goals here? And he said, well, we try to keep our indoor humidity between 40 and 60% because the corpses do better. And I thought, the corpses do better? And I thought, if those corpses are listening, they might be thinking, why didn't we do this sooner? Why do we wait till we're an artifact to humidify our indoor environments? So hopefully some of you are smiling. So what do we do now? You know, there's a vaccine that's on the horizon. Is all of this focus on the indoor environment going to go away? I hope not. Because we now know how important buildings are for our health. You know, in the past, buildings were shelters primarily, and then we got into the energy conservation phase. Sustainability was a big focus. We had new building certifications come up around that we still have, you know, LEED, just to mention one. But COVID-19 has really reminded us of this third strand of why we have buildings, and we need to protect human health. So this is just an article that came out in September in the ASHRAE Journal that I wrote with Mike Schofield around strategies for reducing transmission of airborne pathogens without having ridiculously high energy consumption. So you can take a look at this if you're interested. But so I'm on the ASHRAE Epidemic Task Force, and we are talking about lots of different strategies to keep disease out of our buildings. You know, mid-range humidity control, ventilation, sunlight, UVC, all the things you can see listed here. But how do we really know which of those are the most effective in any given situation? How do we know how to combine those strategies so that we truly protect people from the perspective of health, not from the perspective of meeting ASHRAE standards, not from the perspective of sustainability, but through the lens of health. So why is there a little canary here? The reason is that I'm working now on a sensor suite that is like the canary in the coal mine. The sensor suite identifies indoor parameters that are most relevant for human health, and then collects data through sensors. We aggregate the data, and then we can give a determination from a perspective of health and the microbiome about whether or not your building is really supporting health. I have no idea where that graph came from. Oh, sorry about that. It was behind this one. So, after COVID-19 comes and goes, there are other pathogens just waiting to disrupt our lives. But even beyond infectious diseases, the indoor environment relates to other disease categories, and we can actually optimize our health. It's not just about preventing disease, it's about optimizing our health through proper building management. So I go back to this setting and I think, well, in Papua New Guinea, the indoor relative humidity levels were probably great. People's immune systems had not been suppressed and were probably quite optimized. And we weren't selecting for the pathogenic organisms. And I didn't talk as much about how different conditions select pathogens, but one of the conditions that increases the infectivity in general is dry air. So in Papua New Guinea, none of those bad effects were going on. So I think the people did quite well. And in fact, my very firm belief is, from over 20 years of research in this area, is that if we look at our indoor environment through the lens of human health, if we gather data on the people, we gather data on the indoor environment, we can learn how to manage our buildings to protect humans and begin to turn around this alarming trend. So, as scary as COVID-19 is, it is a new dawn for buildings. And so all of you listening to this, please understand how incredibly important your work is. We need to learn how to truly design and operate buildings for people based on data. So we need to reveal which indoor factors impact our health. And that's what our Canary platform is about. And using occupant health as the lens to look at a building, we've learned again and again that dry air is harmful for people, and the bad microbes love dry air. They do great in it, but human beings don't. So through this lens, we've learned a very important thing, which is that humidification to 40% to 60% is protective, and it's something we can do. So we've kind of covered a lot of things. We've talked about bridging engineering and medicine. We've talked about bridging human health and microbial health. We've gone through some studies on people indoors, and we've talked about, or at least addressed, some of the ways that we can look at a building through the lens of health. And there's my little dog who's under the desk. So please feel free to go through the references in this presentation and email me if I can help you in any way. So thanks.
Thank you, Dr. Taylor. That was informative. And I know it's a different perspective than we're used to, just because you have had that experience in so many different industries, and the way you're able to be the crossroad between the communication of those. Just really glad you got to share that with us. We do have a couple questions, and everyone on the call here, we invite you in the Q&A tab to send more questions for us. So I'll read these for you, and again, just would love to hear your thoughts on these. So the first one has to do with condensation issues in northern climates with relative humidity above 30%. How do we mitigate that issue?
Yeah, I mean, fantastic question. And that's really the big concern. Mm-hmm. A lot of people think that, well, if you humidify your indoor environment and you have any mold, the mold is going to draw that water vapor out of the air and use it for growth. That does not happen. Mold needs liquid water, but that's, I think, what you're asking about. What about condensation in a cold climate? And you're right, that's a problem. But so the solution, though, is to, work on the insulation of your building. Don't turn your indoor environment into the Sahara Desert. And if you actually look at U values and you look at where the water activity of 0.8 will reach when the outdoor temperature is like 0 degrees versus, you can actually see how the R value or the U value, whichever you use, influences where you're going to have a dew point. And so we can manage our buildings. But you're right, condensation, if you have a thermal bridge and you have a cold surface hitting warm humidified air, you're going to have condensation. Needs to be managed. It's a problem. And realistically, I understand that that can be expensive and hard to do. So good question.
All right, the next one for you. Is there a magic number in the number of particles it takes to get infected? I'm assuming that's specifically to COVID, but in general with viruses probably would be relevant for us to hear.
Oh my God, that's like getting to the heart of another question, which is what is that infectivity number? And the ASHRAE Epidemic Task Force, everyone's been going, what is it? What is it? What is it? We don't really know, but I can tell you that if you're more vulnerable to getting an infection, if you can't clear particles from your airways, it will take fewer infectious particles to make you sick. And so, for example, in our Canary platform, part of our data analysis brings in different variables from the Wells-Riley infectious dose equation and adjusts them according to the indoor environment. So the short answer is we don't really know.
Next question. Hydrogen peroxide was depicted as a strategy. Care to comment?
Yeah, so I don't really know. I haven't read the primary literature on H2O2 or hydrogen peroxide, either misting or dry hydrogen peroxide.
Okay.
Whatever strategies we do use, whether it's H2O2 or bipolar or UV germicidal irradiation, one of the things I really hope we remember is that pathogens can evolve. And so we saw with antibiotic resistance, bacteria can evolve and create superbugs. We're beginning to see some resistance to UV light. So just when you think about implementing these strategies, make sure you look at studies that look at the long-term consequences to microbial resistance. But I'm not really an expert on H2O2, so I don't really want to venture an answer.
No, I understand. The next question we have, do we have any data on desiccated droplets staying in the air, as in duration of droplet suspension?
Yes, there is quite a bit of data on that. And I can't, so Jennifer Ryman looked at that in the influenza A and preschool study. So Jennifer Ryman, 2018, it's in the bibliography. But if whoever asked that question sends me an email, I can send you a lot of references about it.
Okay.
But I also want to use this time to tell people, if you're looking at those papers on particles and viral activity, make sure that the particles came from human mucus and protein droplets, not from saline, because the behavior is different depending on the surrounding components of a droplet.
Okay. That's good to know, because I know a lot of times looking through those papers, it's good to know what you're looking for since there's so much information.
And there's contradictory information. So you really need to look at the whole methodology of the study.
All right. There's two questions here, so I'll ask the first one and then I'll ask the second one from this person. Does accuracy of humidity matter? Plus or minus 5%, plus or minus 3%, etc.
I think it sounds like whoever asked that has a hygrometer, so I'm happy about that. And the specificity, I don't think matters terribly, but I can tell you that biologically something happens at 40% relative humidity that's quite magical. So I would want to know if I were 35% versus 40 versus 45%. So it does matter, but I'm glad to see any kind of hygrometer in a building.
And then kind of after that, the question was, how often should you be checking the accuracy of your relative humidity transmitter?
Your hygrometer. So I don't know. I mean, calibration, I think, you know what? I think you engineers can answer these questions about calibration better than I can. So Lizzie, what do you think?
Well, I think if I think about any system we're designing, right, we want to know and have indicators in that tell us it's working how it should. But I think I would just always recommend, if you are designing a system and you have a component in your system, there's a reason for it, and you want it to be something you can constantly be checking. So I think I would have it just designed in and built in with an alarm if it would go one way or another to indicate something like that.
So Lizzie, I see my buddy Jim Coogan.
Oh yeah.
And he's like, so you've been telling us this for a while. Thanks, Jim. There's new data.
Jerry said that earlier too.
He's saying, have you seen changes in the response from engineers and building operators? You know, finally, we're beginning to, but it's not so much because of me going on and on about this as it is from the coronavirus. So COVID-19 has brought new interest in my presentation. But Jim, we do have new data, don't forget.
All right. Do we have any other questions from our attendees? I know, if not, I know I have one last question for you. Is just, in these last several months, what's shocked you the most? I know you mentioned when you first got into finding relative humidity as that key correlation was something that shocked you early on. What about in these last several months where you've been on the task force and been involved with these new studies? What surprised you the most?
That's a great question, Lizzie. Thanks. Two things. One, I've been surprised at how much more willing engineers and building professionals are, how much more interested that professional group is in learning medicine than the other way around. Us doctors, we seem to think our brains are full. We can't learn anymore. That's one thing. But another thing that's really surprised me is how little true health data there is underlying building standards. So we talk about ventilation rates and we talk about, you know, all these different things to do. But if you dig down into the reports, that's usually based on carbon particle movement. It's based on odors. It's based on computerized flow metrics. We need more data on that actually interfaces health and how we're managing buildings. So that's been a real surprise to me and to a lot of our ASHRAE folks.
Awesome. Thanks for answering that so detailed. I appreciate that. Well, I'll call for questions one last time. If not, I'll do a few closing announcements. But Stephanie, thank you so much for your time and your attention to detail with putting together such new and fresh off the press, like you said, information. I know getting reliable information these days isn't something that comes easily, and coming from an expert like yourself is something I think we all are really thankful to have, and we're really glad you came to join us and answered our questions, and can't wait to see what the future holds for what buildings will look like as it does shift into this human health aspect in a different way than it has before because of what we've experienced in the last several months. So,
and any advice that anybody has for me about how to, you know, what research to collect, how to manage our sensors, how to communicate, please, this is a two-way street.
absolutely. And with that, just remind everyone, once you sign off the meeting, you'll have a survey form similar to what you would see after seeing a distinguished lecturer presentation live. So definitely feedback you have. I know, Stephanie, you said you're welcome for us to email, follow up with you as well. So definitely encourage people to give feedback there. And then to keep the conversation going. And then again, thank you to Condair and thank you to Thermosystems for sponsoring tonight's conversation. Very insightful, very informative, and it'll be interesting to see how the future of human health in buildings continues to grow in the next several months. So thank you again, Dr. Taylor. And Liz, is there anything else you would want to add to us before we close?
Just that there's a few more questions coming through.
Oh, there are? Okay. Oh. Okay, here we go. Good. Has your research inspired others to further investigate the effects of humidity and health?
Yes, I mean, that was one of the really exciting things about the MIT student. But if you look at there are lots of papers coming out around humidification and decreasing disease transmission. As a matter of fact, there's a whole community in Texas. Jeffrey Gusky, who's an ER doc, has put humidity sensors in buildings, humidified buildings. He's creating a whole community of buildings with the goal of decreasing COVID-19 transmission. And he has a lot of research behind that effort. So it's kind of exciting because finally we're beginning to see movement in this area.
All right. Is there a trade-off between ventilation and humidity? Are we better off with less ventilation and higher relative humidity?
I mean, that's another one of those great questions. And we can't forsake indoor humidity. So in a cold climate, I recommend, and again, I'm saying this is me. I can't tie this to ASHRAE, although this is what we've been talking about. You know, there's going to have to be some degree of recirculation in your building with filtration, maybe with UVC in your ductwork to clean the coils. I think it's pretty much impossible to have 100% outdoor air ventilation in a cold climate without your energy costs going through the roof, and you'll dry out your building, which is bad. So find a balance. But what do you think, Lizzie, about that?
I think similarly, finding a balance, and then understanding what is specifically going on in that space so that you are making the best decisions, right? Every space is designed for something specific. And it should be. So I think taking into account those types of things and what the expectations are of what that space is doing and how you'll do it will definitely go into shaping that strategy for having that trade-off. If you're trying to work with equipment, say that's already there and make it better versus you have that ability to put something brand new in, kind of working within that space, I think would be my perspective on decisions you can make with that trade-off and what to look at.
That's one part. So the Canary sensor suite is designed to begin to answer that question. You know, if you increase your outdoor air ventilation, what does that do from a health perspective, and how can you manage all of the different components for health?
Yeah, and I think this question relates to that. What was the sensor suite you discussed that you mentioned? So I think that's what you were talking about.
Yeah, so actually, I'm started a company called Building for Health, where we actually have created a sensor suite with a partner, which is geared to gathering metrics for health and then aggregating and analyzing the data with a feedback loop to tell buildings, okay, building managers, this is what you can do. So it's the B for H, Building for Health Canary Sensor Suite.
All right, another one for you. The current trend to increase outside air would seemingly be injurious as weather gets colder. Any comments?
Yeah, I think that's a great point. And I think, again, filtration, other air cleaning strategies with some degree of recirculation is going to be inevitable.
All
but again,
right.
I bet the engineering audience can answer that better than I can.
And too, right, with all of this, there's so many different variables involved with making these decisions, right?
But I think that the human health lens helps us prioritize.
Absolutely.
Especially once we make those indoor metrics visible. the ones that truly relate to health.
All right. Is there any intention of expanding the correlation of relative humidity with the with the incidence of disease going from remission to active?
Yes. We're looking into resurgence of diseases as well as diminution of diseases as it relates to humidity. And actually, again, whoever's asking that, email me, because we have a wealth of studies actually not only in viral infections, but also in bacterial infections and how they relate to water vapor levels, both when the diseases are on the rise and when they're coming down.
Yeah.
If I had like another couple hours, I could show you a lot more studies.
We'll have to have you come back next year after more studies have come out too. All right. So,
These are amazing questions.
yeah, we definitely have a lot of perspectives and experience. I know too, usually on our calls, there's a lot of curiosity, a lot of questions that come through. So
that's fantastic. That says you were a really good chapter, in my opinion.
Agreed. All right. Anything else, attendees, that you guys want to bring into the discussion? I know we've had a lot of really good questions, and now making sure I'm not missing any. So I have my questions tab maximized so I don't miss anything. So I'll give you guys just another minute or two to ask anything else. I know I see some stuff in the chat. I think we've talked to most of that there. Anything else, group?
Well, thank you so much, everyone.
Yes, thank you. And again, everyone on the call, please continue the conversation. Reach out to Stephanie and to fill out the survey. I know we want to have more webinars that are informative. Again, our next meeting is going to be in January for ASHRAE, and then to the next couple weeks, there are some gatherings for YEA and women in ASHRAE. So make sure look into those. And if there's no other questions, Liz, is there anything else you want to add before we end our meeting?
No, that's it. Thank you so much, Stephanie.
Right.
And also Lizzie, thank you for being a great moderator for us.
Yeah, thanks.
Some great feedback in the chat.
All right. Well, everyone have a great rest of your night. Thanks again, Stephanie, and everyone have a great rest of your night.
Thanks. Take care, everyone.
Take care.
Be safe.